Hello, everyone, and welcome to this panel discussion. It's our pleasure to welcome you today for our next session. My name is Arthur Valker, and I'm coming to you from the United States. And I have with me some colleagues that really need no introduction. Welcome to this panel discussion. It's our pleasure to welcome you today for our next session. My name is Arthur Valker.
Somebody has to mute his mic.
Is everybody okay?
Yeah.
There we go. Oh, much better. Sorry for that auspicious debut, everyone. I think we're good. Let's just check, make sure we have no feedback. Okay. So everyone, again, I would like to welcome you all to today's panel discussion. My name is Arthur Valker, and I'm joining you from the United States. And I have with me some esteemed colleagues who are also members of the Turquoise Study Club. So as members of the Turquoise Study Club, we are very honored to be working in conjunction with Istanbul Kent University at their 3rd annual Free from Caries Symposium. So I would like to introduce Dr. Gurvinder Bhirth, Dr. Andrew Chandrapal.
Hello.
And you have probably just seen him about 10 minutes ago from Greece, Dr. Pantelis Kouros.
Hello again.
Thank you, gentlemen, for joining us today. And Pantelis, we know you might be a little bit tired, so we're going to put you last.
I'm fine.
Just so everyone knows, all programs that were shown will be available for playback on this channel on YouTube. We're also going to be, as you know, live on YouTube. And there will be programs, as you have seen earlier in the past 2 days, from really phenomenal world-class clinicians, including Joanna Garces, who was yesterday, and our very own Pantelis Kouros, who apparently is going to do some more lectures today. So as we have seen in the symposium for the past 2 days, we have been exposed to a lot of really fantastic information about oral biofilm, the oral environment, and ways for us to help prevent the spread of dental caries and their ill effects. In today's panel discussion, again, I have these very, very world-class gentlemen who were kind enough to join us today. And let me just say hi again, because I didn't get a chance for them to say hello back. So hello, Gurvinder. How are you doing today?
Very well, thank you.
Good. And Andrew, how is everything?
All good, thank you, Adi. All good, thank you.
And Pantelis, I'm not saying a word to you because we know you're probably tired. So the approach we were going to take today for today's panel discussion, and we absolutely wholeheartedly ask that you provide us with some questions along the way, but we're going to discuss various techniques that we can use within the realm of minimally invasive dentistry, or what will sometimes be called micro-invasive dentistry. So we're going to discuss some tactics that we can use. And then we'll bring up some topics that we have here, and we'll do a bit of a roundtable discussion. Because we have such esteemed clinicians with us, I think it'll be very nice to see opinions. And if anyone out there listening has any particular opinions, we would certainly like to hear it, and we definitely will open up the floor to any discussion. So as a way of starting, I would like to have Dr. Gurvinder Bhirth present for us on his presentation. So Gurvinder, if you're ready, maybe we can start off a bit.
Sure. Okay, I'll switch. Give me one.
And so, Gurvinder, as you're loading, would you mind just giving us a little bit of a background for the people? I'm sure they know who you are. We do know that you do practice in London, England. You are definitely known for your direct composite work.
Yeah, I mean, I'm based in Birmingham, which is kind of central England, and predominantly it's kind of working in prosthodontic and kind of restorative work. And that can go from primarily a lot of direct restorations, but also kind of going on to implant restorations as well. I should be clicking on that. So it should be kind of help me on screen now. So I'm just going to really kind of run through a kind of a case of a kind of treatment of white spot lesions. It's something that's come up an awful lot, and something that we do see kind of in our younger patients. And what we want to do is trying to treat these kind of cases in in the most minimally invasive way as possible. And again, one, trying to keep as much tooth structure, preserved for as long as possible, and not trying to do anything at a very young age, which will then be to the detriment of the dentition, throughout life. So I'm going to kind of present a case which I saw this patient a few years ago. She was only 16 years of age at the time, and her main concern at this stage was obviously the white spots and the white patches on her teeth, but also the discolored restorations. She kind of gave a history of these restorations were kind of placed when she was about 14 for the trying to elimination of the previous white spots on those two centrals. And now it was a combination of both the white spots and the discolored restorations. And we wanted to try and do something which was going to be kind of the least invasive, which will still keep the tooth structure intact. She came in asking for veneers, which it was something which, at that age and, for this type of treatment, it was not something that appropriate. So when we start looking at the case, you can actually see there's quite a disparity between kind of the actual original dentition. On the canines, there's quite kind of high chroma. There's high value, obviously, with the white spots, but also kind of dropping in value and high kind of chroma within the old previous restorations. And when we do a kind of cross-polarized kind of shot, again, that disparity comes even clearer. So when we try and look at kind of a case like this, it's basically treatment planning. And the reason this failed, in the first place was the lack of treatment planning. It's very easy, if we're trying to eliminate white spots or trying to do any sort of treatment, that we jump in very, very quickly thinking that we can cut out or remove the kind of white lesions and replace those by, composite resin, thinking that it's going to be a minimally invasive way of treating this. Now, without the lack of kind of actually, proper treatment planning, that things can go askew quite quickly, and which can actually end up causing more damage to the patient, and the aesthetic result can still be kind of quite poor. So something like this, what we have to do is trying to plan and try to look at that. There's not going to be no one solution which is going to treat all three areas. So you can see by the cervical areas, there's kind of quite a diffuse area of white lesions, going to a larger kind of more opacious areas on the kind of incisal edge, and also the higher chroma and low value within the old restoration. So there isn't going to be a single treatment modality which is going to treat this, whether we do this by composite resin, whether we do this by resin infiltration. So we have to try and pick the most appropriate kind of plan for treating this case. So trying to separate those three regions and doing those kind of what would be the kind of most appropriate for each lesion. So where we've got the more diffuse kind of white spots, particularly in terms of the cervical areas, those are quite diffuse, those are quite superficial, and those will work quite well for kind of resin infiltration. So it's just treating those areas with just resin infiltration, and we'll kind of expand on kind of the meaning and the kind of treatment modality of that. Where the areas are a little bit more opacious, where there's more kind of hypermineralized and hypermineralized enamel, it would mean that we have to then remove some of this enamel, okay, to try to get to the deeper lesions. Okay. That would mean taking some enamel away. And again, with this, it is only a very, very slight amount of preparation. And therefore, anything that we do remove, we have to protect the tooth and replace with just the enamel shade resin. The old restorations lacked kind of opacity. They just had most likely just an enamel shade, which then therefore dropped the value on these restorations. So what we have to do is look back at relayering those teeth, those kind of areas, both in terms of kind of having a dentin layer to increase the reflective and the opacity in that area, but also then placing some enamel and potentially some effect shades in between to try and give a little bit more of a youthful appearance and trying to restore this child's kind of dentition back to something that's quite youthful. Resin infiltration itself, has been around for an awful long time. Raymond Bertolotti, sorry, kind of mentioned this kind of going back in the kind of mid-90s. But essentially, we get the white spots because they're caused by a scattering of light. The refractive index of air is much lower than enamel, so we end up getting more scattering on the surface of the tooth, which will give a kind of whiter appearance to the tooth itself. We then use to try to kind of treat this is basically hydrochloric acid. The use of hydrochloric acid is to try and remove some of this aprismatic enamel some of these and open up the prostheses within these spaces to try to remove it, to get access to this water. Again, we can place ethanol into this kind of region. Again, firstly, it eliminates the water that's in those prostheses because that's what we want to get into. And secondly, it can actually give us a preview because the refractive index of the ethanol is much closer to natural enamel, being at 1.38. Now, it will only give us a preview for a very short time because as the ethanol evaporates, it actually dehydrates the tooth even further, which is, in terms of appearance, will give us back the white lesions. But in terms of it's a good point, it's actually removing the water within these porosities. Then we'll kind of replace those porosities with TEG DMA kind of resin, which again is very, very kind of low viscosity. It's very, very fluid, so therefore we can actually penetrate into these porosities much easier. And that's the whole point. Once we remove the water, the kind of resin infiltration will go into these porosities. Because the refractive index of TEG DMA is much closer to 1.52, it can make those white spot lesions kind of almost disappear and actually kind of integrate kind of optically more into the natural kind of underlying enamel. Whenever we're doing these cases, any sort of bonding, we need good isolation. So here we're kind of isolating the whole upper arch, trying to get good access to the way up to the cervical areas. And once things are kind of isolated, you can actually have full access to all these areas. Now, the one issue with this is very easy to jump in and actually try to do the resin infiltration or start the process straight away. But again, it's trying to remove this biofilm. Okay, the biofilm will do a couple of things. One, it'll stop any bonding or actually adequate etching, adequate bonding, but then also cause marginal micro leakage kind of with any resin infiltration and also with the composite kind of bonding onto these teeth. So again, these were cleaned. You can do a number of things. You can use pumice, you could use kind of silk, calcium phosphosilicate, or you could actually use sodium bicarbonate. It's just trying to remove this biofilm, trying to have a very, very clean kind of substrate that we can actually bond to. So once we've got that clean substrate, you can see also in that time, things dehydrate much further. So those white kind of areas onto the cervical areas become much, much kind of higher in values and actually much more noticeable. Okay. And once these old restorations were removed, again, there was removed under the scope as kind of carefully as possible. You can actually see the amount of damage that was done kind of by the previous clinician. It's only from this angle and these kind of views, we can actually see the extent of kind of these lesions and potentially the damage that has been done. Now, whether this was the extent of the lesion or whether this was kind of overzealous preparation, it's impossible to know without a previous photograph. Kind of applying kind of the HCl kind of acid, you apply this on for about 2 minutes. Now, it's quite important to try to protect the dentine, and that was protected in this case here with just some glycerin gel, because again, you will get greater demineralization with that strength acid onto dentin. It's something that we don't want. One, for the damage of kind of the collagen kind of matrix, but also then kind of the subsequent lack of or decrease in bond strength. That's washed away. When it comes to actually placing a preview of this area, okay, we can just place kind of some of the ethanol. And the whole point is that you can see by the last kind of photograph, the kind of around the cervical area, the value kind of will decrease and the chroma will increase, which is what we're expecting because we're trying to remove the white spot lesions. Whereas if you look at the incisals there, the value is still quite high. Okay, and that's something because the kind of opacious area will not have the same penetration. It's something that will then give us some justification to trying to remove some of this most opacious kind of enamel area to allow some further penetration into there. Now, whenever we look at kind of preparation, we're always looking at taking something substantial off the tooth, but we're kind of looking at something that's minimal. Okay. So you can see the kind of the pre-op and post-op in terms of preparation. It is something that can be just with particle abrasion. I think with this case it was just 27 micron aluminum trioxide, and to remove that kind of superficial kind of very, very opacious enamel. Not removing it entirely, okay, because again, like the areas at the top, if we do leave a kind of diffuse layer, that will then kind of work quite well with just the resin infiltration. So when we've got this clean substrate, it's quite a good point to actually stop and then reevaluate what we want to do with these areas. Now, one of the things that was still facing is quite an opacious area on the incisal edge. Now, I decided at this stage we're actually going to retain that because we could still keep that as a halo, which will then still help kind of give quite a youthful appearance, for this patient. We could do simple layering, okay, kind of into these faces, kind of a natural layering technique by Didier. And again, just to try to give us some opacity, some reflectance, to try to break up and give us some form to the mamelons. On top of that, we could actually place some opalescent tint to try to give a more kind of youthful appearance. Now, on the laterals, we could just actually place the tint alone. There was going to be no dentine placement, but given that optical effect of actually placing the tint in, it's almost a reverse kind of modeling, that we can actually just layer this with kind of enamel shade to give that kind of almost like a pseudo effect of kind of opalescence in these areas. So again, when we go for the kind of a cross-polarized shot with the ethanol, by doing the ethanol preview again, you can see there's a more uniform now of chroma within kind of that tooth, but still on the incisal edge, that kind of keeping that kind of quite opacious kind of enamel edge will give us that natural looking halo into there. So when we do give the resin infiltration, you can see there's a much higher increase in chroma, a lowering of the value, which is then trying to kind of mask those white spot lesions and give a uniformity across the whole tooth. And then it gives us something that we kind of do every day. We look at teeth, and we look at teeth where how we're going to model those and how we're going to now integrate kind of any sort of direct composite restoration to these teeth. So it's again natural layering, something that's a very kind of simplified kind of technique. So it's a single mass of dentine, which will then give us some kind of reflectance and opacity, leaving some space for some kind of opalescent tints, and then a simple kind of achromatic kind of enamel over the top to provide some translucency. So again, the simple modified kind of dentine layer, again leaving some space at the incisal third, and again giving this area the same mass by thinning this out onto the mamelons will give us an increased translucency within the same dentine mass. Placing the tint in between and being still shy of the incisal edge, and on the laterals it was just the tint itself, just formed without any dentine layer. Again, this is quite an important slide. I mean, at the moment there's a current trend of using composite and using it as veneering and veneering the entire surface of the tooth. Here you can see the enamel shade is only placed on wherever there was any sort of preparation, and then where there is only any need for actually some enamel layering. By placing more composite onto teeth, there's going to be more maintenance. So if we cover the entire surface of the tooth, there's going to be a couple of things. One, we change the form of the tooth. We can't ever get the natural appearance because we're actually laying the tooth entirely. And secondly, it's greater maintenance. Okay, composite over time does change. It does require kind of both repolishing, refurbishing, and eventual replacement. So we want to limit those areas. So if we don't need to, veneer an entire tooth, then it's something that we can still get optical integration without having to kind of do a complete composite veneer over these areas. So with some very kind of quick kind of finishing onto these teeth, and with the medium onto the rubber diamonds in place, we can start to see there is at least some integration within that. There is dehydration, obviously, but again, there is some integration between what we've layered into the underlying tooth structure itself. A week later, okay, again, we could see some of this opalescence coming through, the halo kind of onto the incisal edges. But again, they do need to require some finishing and obviously some polishing. So it's again going through kind of, set protocols. And when we do a finishing, is actually working back to basics. So we will go with our transitional line angles to give the form of the teeth and give us the kind of perceived width of the teeth, height of the teeth. Going on to a secondary kind of anatomy, going into kind of the development of the groove. A tertiary under the surface, because again, this is being a 16-year-old, they will tend to have still some tertiary kind of anatomy onto these teeth. This can be done with a very fine diamond. And again, then polishing the teeth, okay, to give it kind of again, rather than a very, very high gloss, is giving something that's still a soft luster. But that's what generally teeth have. And even if you look at the natural teeth, haven't got actually a very, very high gloss. So when we see these teeth kind of, or a month later, you can see there's integration now, both with kind of the original kind of resin infiltration of the spical area, again, where we placed composite resin onto the laterals, canines and premolars, which is the enamel shade, but also then when we did the actual layering on the centrals, both dentine and kind of the enamel shade. Again, and there's kind of integration between those, so we can see a secondary and tertiary anatomy onto these teeth. So again, a review, we've got a kind of a patient at 16 years old coming in with kind of this, and then over time, with a little bit of planning, we can actually still keep these teeth kind of restored, okay, in a very, very minimally invasive way. And again, we can keep preserving as much tooth structure, for this child who's, I say, he's only 16 years old. And then even at kind of 2 years down the line, yes, there is a slight loss of kind of polish, but that's something that can be very, very easily buffed back up again. But the actual integrity of both the resin infiltration and the composite onto these teeth is still very much intact. So thank you. Okay, and I'm happy to kind of answer any questions or any queries.
Thank you, Gurvinder, for that. That was, as usual, a very spectacular case done by you, but we expect no less. Gurvinder, while we're waiting for some comments, I do have a question about that. Now, you did show a 2.5-year follow-up. In terms of patients where they may not receive a composite restoration, in other words, if you're only going to use icon or resin infiltration as a final treatment, how do you find yourself clinically, or and gentlemen, if you have any thoughts on that, please, as well. How long do you find that something like resin infiltration works as a treatment modality without recurrence of the preoperative situation?
I think one of the issues with resin infiltration and the way that it's actually kind of perceived is it's almost like a treatment, and once we do this, we stop straight away. I think it's quite important with when we're doing anything direct in terms of composite, that we need to polish. We need to finish and polish very well on the day we do the actual treatment or on a subsequent review visit. The polish and finish that we do on day one, okay, is what determines the polishability or the polish retention on a restoration in 6 months' time or a year's time. So if it's polished very poorly on day one, it's going to look very poor in 6 months' time. So whereas if you do take our time, we do get restorations looking much, much better. Yes, I mean, I always tell my patients that with anything that we do with the resin, they will need a repolish, a refurbishment, or eventual replacement. And that way, patients do expect if you do need to do something to buff something up, it can work quite well. It isn't just a simple case of placing the resin and allowing some glycerin gel and curing through that. It is actually trying to actually polish that. It is only resin. It is only unfilled resin, so it will break down. Okay, but it's not going to break down within the tooth itself. So if we polish that and we get that as well as it will require less maintenance, but still some maintenance.
Very good. Okay, thank you for that question. We do have another one, and it's how are you finding something like resin infiltration versus something like for brown spot lesions? Now, we know that resin infiltration is great for white spot lesions. Do you have any suggestions for brown spot lesions?
Okay, whitening. Okay, so just standard tooth whitening with something like 16% carbamide peroxide. So something slow over a period of time will work much, much better with brown spots. For resin infiltration won't actually work particularly that well with brown spots, but standard carbamide peroxide over a short period of time will work much better. It's very, very much predictable.
Thank you. So we do have a question, Gurvinder, and it's, is it similar at recall cases with icon? I see what he's asking. Do you have similar outcomes in terms of recall with icon and your laminate veneer cases? Because you were speaking about polishing.
Yeah, I think you probably find composite retains a polish better. But like that case there, I mean, she's been there about 2.5 years. And every time I've said to her, do you mind, me polishing these back up again? And she said, well, I can't see in the lack of polish, because again, when we take these photographs, we're kind of drying these teeth. Okay, so it's not in the normal kind of standard way when they're smiling, which may have a coating of saliva. She can't actually see and perceive that lack of polish, whereas I can, and all of us, viewing this, we can do. But I think composite generally will retain the polish much, much better, because again, it is something that's filled, and we're trying to polish those filler particles rather than polishing the unfilled resin, which take the amaze.
Thank you, Gurvinder, and thank you, Sugar Excuse, for that question. And Gurv, I have to apologize. I said you were from London. I didn't mean to insult you. I forgot you're in Birmingham.
No problem.
Gentlemen, do you have any experience with resin infiltration that you care to share? Are you doing it as a routine part of your practice?
Yeah, I mean, it's a technique that certainly I think, as Gurvinder showed beautifully, if you know the indications clinically and don't feel appropriate to apply it to every single clinical scenario, it can have very predictable results. And in my own hands, I think in the early years of doing it, I was one of those that felt guilty of applying it both to white spot lesions and to brown spot lesions. And then as the technique of resin infiltration evolved, and as the experience of other colleagues and mentors around us came about, it was realized actually that bleaching is a really effective way of then eliminating or subtilizing the brown spots. So for the white spot lesions, it's a very predictable way of going. I think it's difficult in some respects when you're looking at high value cases because of the resin itself. And so you end up sometimes having to layer appropriately when you're dealing with cases where the actual block shade of the tooth is quite of a high value. So that's perhaps one of the limitations. But I would very much like to see beautiful cases like Gurvinder just showed at a recall as it goes further on, just to highlight the importance of this technique, particularly for young individuals.
Thank you.
Okay, it's my turn. Okay, Gurv, I mean, it was an exceptional result. But let me share my experience. When this icon came out first, I had the opportunity of having a personal chat with the creator of the technique, which is Professor Parrish from Berlin. And when he was explaining the thought, the mentality behind this thing, he told me that he was using the HEMA monomer, which is actually the hydrophilic monomer, which is contained in the adhesive systems. So my first question is, why don't you use any highly hydrophobic monomer, like, for example, a silurane monomer, which is through the hydrophobicity will give more stability to the results. He explained to me that it's the only small enough monomer to be able to penetrate the structure that the acid is leaving behind. So he selected this for penetration reasons. The actual initial will of him was to infiltrate the proximal surfaces of molars and premolars, and not to be used on white spots. So when it comes to the anterior region for the white spots, then through the 5-year follow-up review, which first came out, and actually was telling what I said, that it's going to be dissolved and discolorated, then the protocol has been changed. They started to cover with, like Gurvinder did, with hydrophilic flowable or non-filled resins in order to prevent the dissolution of the HEMA to the oral environment and to prevent the discoloration. But when it comes to the white lesions, we have to be able to estimate the depth of the white lesion. And most of the times when we see an intense white lesion and we want to be minimally invasive and we start to rub with the acid, I don't know how many of you are able to remove the white lesion completely, or then we start with the air abrasion systems, or maybe we can pick up some handpiece and drill out the white lesion. I mean, what kind of minimal invasive is this? So what I mean to say is that we have to be very careful to the selection of the cases and to try to estimate the depth before even we start. Most of the cases we have to inform the patient that it is a possibility that we're not going to be as minimal as we want to be. So first of all, we have to take consent on the case that we need to remove more of the white lesion to be able to restore it. That's my opinion. I don't know if you guys have any objections of that. It's personal opinion. It's how I see it.
I think, as you try to say, the case selection is critical.
Yeah, exactly.
It's something which, again, unfortunately, it's been used because somebody sees a white spot and they jump straight to kind of a product. It's not a product that's going to solve problems. It's a technique. It's helpful in our armamentarium, but it's not the be end and all solution to everything. And this is the problem. We end up seeing something that's quite opacious and jumping thinking resin infiltration will treat this. And then we go through 1 cycle, 2 cycles. And I've seen people kind of mention that they've done 18 cycles of hydrochloric acid, which is they might have just got a burr and actually gone straight to the tooth. Just because you're using acid doesn't mean that you're not doing the same enamel removal as say you're actually picking a high-speed handpiece. So I think it's the information that we need to plan these cases, which is critical, as opposed to just thinking this treatment modality is going to treat a particular problem.
Thank you, Gurvinder. Gurvinder, if you don't mind, we have also one more question for you.
Sure.
And it's just about the polishing instruments that you prefer to use when using resin infiltration. Again,
a lot of times we will normally just go over with discs. Okay, sometimes you just go through your normal routine kind of standard disc. So they'll go from a medium to a fine and even to a super fine. Wipe away between each disc, so you're actually getting any of the residue of any coarser disc kind of beforehand, and then go with a pre-polisher. And the critical stage is once you've used the pre-polisher is again get a gauze, wipe away that rougher material before you go into the polisher. Okay, because otherwise all you're doing is actually getting the coarse material running over the same tooth, and then you're finding it actually you're not polishing. All you're doing is rubbing a coarse material into the same tooth structure, even with the polisher. So it's quite critical to remove between each stage, clean the tooth with just a simple gauze and some water, and then just go slow and take your time. Most pre-polishers will work very much predictably. Most things people will speed the polish is too high, which ends up cooking the composite and generally the tooth as well. So slow down, take your time, and you will get something that's very predictable.
Thank you, Gurvinder. So that was a really great vignette. So we really appreciate that. Andrew, do you want to go next? Do you want me to go? I'm going to be doing a bit of ortho and occlusal analysis. Will that set you up better?
Sure. Yeah, I can go after you. Yeah, mine has a little bit of occlusion base to it, so or vertical.
Okay.
Change.
Oh, even better. Okay, so then, so for this next one, I'm going to be quite brief. I just want to. Oh wait, we have one question before we begin. Sorry, if you don't mind, this is for Pantelis.
Yeah.
Pantelis, is there any solution for detection of the depth of the white spots?
I don't have any personally. Do you?
No. The problem with that is it comes with experience that you have to then try planning. You can do photography. What I've tended to find is you can actually try placing, the usual things, turning things black and white, so you can actually see the depth of a lesion and seeing the opacity on some of these lesions that stand out a little bit more in black and white. You can increase the contrast and decrease the brightness, which again, you want to be able to see within kind of the lesion which areas are much deeper. It's very rare that you will have just a solid, intense spot. You will have an intensity surrounded by a diffuse area. And the mistake that can be made is that you treat with resin infiltration and you end up still getting the isolated opacity and then going work again and again. So you can be disappointed with the result. The patient is generally happy because their kind of white spot is reduced, but the aesthetic result can be still not what you desire. So it's difficult, but again, it comes with experience.
Yeah, I wanted to highlight this one. Experience plus transillumination, maybe, because it's not quantifiable. It's a question of estimation, personal estimation. So I don't have any straight answer to provide.
Okay, but thank you for that. Again, a really great segment. And if you do have questions, please keep them coming. We're more than happy to answer them. In the next segment, we're going to just switch a little bit. And what I just would like to speak with very briefly is just on the topic of how do we treat minimally invasive smile designs. And I don't know if any of you gentlemen are doing any type of orthodontic therapy. I do quite a bit in the office. So I do want to share sort of where I come from, but I will be honest, often I will have patients who absolutely refuse to do orthodontics. And do we have to automatically do a very, very popular thing? And I hate to be the nation that claims it, but we are the country in the United States that created the instant orthodontics, or the orthodontics via burr, if you will. And so just, I don't know, maybe as penance, just to discuss two strategies we use when we're dealing with such situations, and just to share a little bit of how I might deal with both. And I'm hoping that this will lead us to what Andrew is going to talk about, because Andrew is going to have some really fantastic stuff on incorporating technology into minimally invasive treatment, especially when increasing vertical dimension. So I'm going to now just share my window, I hope to. Okay. Okay, let me just get this. Yeah, I see we're there. I'm just going to start with just two cases if I can. But as I start, I do want to just share this consideration. And as we are dealing with a micro-invasive approach, I do want to put these two considerations up. And that's the first thing is, do we have to compromise aesthetics to preserve tooth structure? And then conversely, do we have to compromise tooth structure in order to achieve an aesthetic result? So there was that very common phrase that was, especially when I was in dental school, that was quite popular, called instant orthodontics. And the problem though with instant orthodontics, and by instant orthodontics, I'm referring to the procedure where if teeth are malaligned, you would typically get a wax up from the laboratory, and you would prepare the teeth using a high-speed burr in such a way so that they would fit into a somewhat uniform shape to the arch, therefore creating this smooth, rounded look without having to go through sort of the difficulty and time and expense of instant orthodontics. And that's one way to look at it. But the thing is that often dentists, and I'm glad to report that it is certainly less, but they would prescribe these multiple reductive or amputative restorations on virgin teeth to correct this existing malpositioning. However, there's three issues that can occur. One, because the teeth were not moved, the occlusal loadings may not be properly directed. The emergence profiles may be improper, leading to periodontal issues. And thirdly, and we see this quite often, is that interproximal papilla may be impinged upon. And I know, in the United States, that often a lot of general dentists will incorporate some orthodontics, but often they are not perhaps using it as much of a modality as they should. So I would just like to share these two approaches, and then we can have our discussion. And this was a patient who came into the office, and as you can see from her occlusion, that she does have a posterior crossbite. She has certainly malalignment of the anterior and posterior teeth. And she came to my office seeking some type of improvement to her smile. she absolutely refused to do orthodontics, because in a case like this, and I will show with my second case how I actually prefer to treat a case like this, a patient like this who is absolutely refusing to do any type of orthodontic treatment is certainly a candidate for instant orthodontics. But I find that to be a very, very poor treatment choice. I would refuse to do it. So in cases like this, what I would opt to do is take a certain approach. Now, before we start a case like this, when I have a patient who is with a very unusual bite, and they're going to refuse to alter that bite via orthodontic therapy, what I will often do is put them on an occlusal analyzer. I have no financial interest to disclose with this company, but I do use a product called TechScan. And essentially what it does is it's a force plate that measures the amount of pressure distributed across the arch. If you're not familiar with it, I'll just make it very easily. On the left side of the screen is the arch form, and the teeth are numbered, and they're done in the universal numbering. So tooth number 3 here would be, I believe, 1-3, and tooth number 14 would be, oh good God, no, it would be 1-6, and the other would be 2-6. So where you see number 14, that's tooth number 2-6. And gentlemen, if I'm wrong, please correct me. But in this patient, at her preoperative maximum intercuspation, she was biting almost 95% on her left side. She had virtually no contact on the right side. So again, a patient like this is absolutely indicated for orthodontic treatment. But if the patient refuses, is it in your purview to tell the patient, look, I'm not going to treat you? Or to say to them, well, the only way to treat you is to start drilling. So the approach we're going to take will be quite straightforward, can be somewhat reversible, and this was how we did it. The first thing we were going to do was we were going to do some additive composite buildups on the right side in hopes of equilibrating the patient's occlusion. Now, she had some jaw issues, which I don't want to go too much into, but she did have some issues with her occlusion. She was very uncomfortable. She had a difficult time achieving a stable occlusion. And again, when you look at the results of that analyzer, she was biting 95% on her left side in maximum intercuspation. So we want to now level her bite. And this is the strategy I will often employ in these cases, what I will do is I will do single shade composite veneers. They can always be cut back as a polychromatic approach. You can have an approach like the gentlemen like Gurvinder and Andrew and Pantelis do. But in these cases, often I find that just doing a single shade is enough of an improvement. These will also be additive. There will be nothing reductive on any of these teeth because the patient understands that there will be a bit of a compromise when this type of situation is put upon the clinician, meaning you would get a much better aesthetic result if orthodontic treatment was included. However, if the patient isn't willing to accept the compromise, then they can have an improvement that would be to their benefit, but at the not at the cost of tooth structure or healthy tooth structure. Then, of course, as with anything, the patient will go on a mouth guard or retainer. So this is just a photograph of the right side where we did some composite buildup. And what we used is we used the occlusal analyzer actually as our guide. In other words, we would build up the bite. How does it feel? It feels okay. Then we would put the patient on the machine until we're able to create a more even bite pattern. And so this was the bite pattern that we were able to achieve. Now, again, if you are not familiar with this equipment, you can see at least just by visual inspection that the bite forces, the distribution across the arch are more uniform. So this is the bite we were able to achieve by adding to the right side. And then we did the direct composite veneers. This is what she looked like in post-operative intercuspation. She stayed like this for 1 week. Then we brought her back to do a final polishing. Now, is this an idealized occlusion? Is this an idealized result? And the answer obviously is no. However, this is most certainly a minimally invasive treatment, a minimally invasive outcome, and I believe we have acceptable enough aesthetics for the patient. But the patient has to understand that this is a compromise. Now, can it stay? And the answer is absolutely if you mitigate any occlusal forces. And in this case, the patient is here over 1 year. This is almost maybe 2 years now. And she came back and we did a bit of work on the lower anteriors. Again, this is done with no reduction of tooth structure. But again, this is not an idealized occlusion. However, we are able to maintain it, and we can see here at the 1 year maximum intercuspation that the patient is absolutely stable. Now, if I had my druthers on every case, they would tend to go a bit more like this. Now, this case is interesting because this is the friend of a dental resident who was told by his dentist, and just as a point of information, this patient has no caries, but was told by his dentist, and this is a very common thing, that I can fix your smile. What we're going to do is we're going to do 10 veneers, and I'm going to do a root canal on number 1-1, the right central incisor, and then we'll put 2 crowns there, because this is, again, this is ortho via burr, or that phenomenon of instant orthodontics. But is there a much easier and more biologically effective way of providing a solution here? This is just some lateral pictures of his occlusion. This is an occlusal view preoperatively. Now, when we start any type of orthodontic treatment, we always have to do our analysis. So we'll do our tracings, we'll do our angle analysis. So this patient had a class 1 molar and canine relationship. If anyone is interested, I put this slide back. For those of you who are interested, I'll be more than happy to answer any questions about orthodontic analyses, because if any of you are doing any type of DSD, or if you're doing any type of CAD/CAM orthodontics, and we are doing that in the office, the basis for the tooth positioning and tooth size discrepancies really came from this Bolton analysis. And this analysis was actually published in 1958. So it's nothing new, and all it does is it compares the size of the upper teeth to those of the lower teeth. And there's a certain range, but just to let you know that the basis for DSD really comes from a lot of the Bolton analysis, as well as a proportion analysis. So this was done in an analog matter just for demonstration. Today, this is done very, very easily and effectively using a digital smile design program. But I did want to show sort of where the origins of the computations came from. And we know one of the things about height to width ratios is that we want the height to width to be about 80%. And in our case, we saw that the front teeth were slightly thin compared to the rest. So I will show you visually what that looks like. And if we were to look at the proportions in the preoperative situation, we can see that the central incisors are a bit flat on the mesial. As well, they are a bit narrow compared to their height, especially compared to the other teeth. So the height to width ratio is a little bit less than idealized, but we can use that, and we can use that to help create a more harmonious smile. So we will use something called the golden proportion analysis. I will not get too much into that, just to show you that the bottom line of doing these analyses was that we found we had to increase the width for each central. So what does that mean for us? Well, when we have a case like this, it's always done in the same manner. And that's, firstly, we'll always ensure the health. And that's, I'm sure, what the basis of the symposium is for sure, right? We have to ensure that we have the health of the patient first. So any type of periodontal issues must be dealt with primarily. And then we're going to use some clear aligner therapy to straighten the roots of the central incisors until they are parallel. And according to our calculations, we will have a resultant 2-millimeter diastema. During the last 2 weeks of orthodontic therapy, the patient will be bleaching their teeth using the aligner as a tray. And then finally, what we're going to do is we're going to now close this resultant 2-millimeter diastema, 1 millimeter per tooth, using a BioClear matrices or injection molding protocol, although there are many, many ways to do this. So as we're continuing, this is where the patient started, and this was the proposal from the orthodontic company as to where we wanted the teeth to end up. And this is where the patient tracked, meaning that the patient was quite compliant. They were doing a very nice job of keeping their, wearing their aligners, of maintaining their hygiene for the most part. And so this is what the teeth look like immediately post-op. It's a little bit skewed, and you can see we have a bit of a black triangle there. But if we have some analysis, we can see that we have more idealized the patient's proportions. And we know that from the study of Parnow and others who followed, that if there's less than 5 millimeters between the contact point of your restoration or of the teeth and the crest of bone, a papilla would be present. And sure enough, at the 1 week follow-up, you can see we're starting to develop the closure of the papilla. Here it looks from the occlusal. Now, this is quite an old case, so there would be a few things to correct. But as we can see, that the bottom line of this case is that using the triad of orthodontic therapy, bleaching, and any type of restorative work, we were able to treat this patient without any removal of tooth structure. This patient was going to have 10 veneers, 2 crowns, and 1 root canal. And I find that to be a gross overtreatment. Today, we can do these cases very easily, and I had done this when I published this case using a very analog method. But again, now with the advent of digital smile design and ancillary software, this can be done very easily. This is a very, very simple treatment modality, and we are able to save our patients and their teeth. So when we put this consideration, I hope that we see that we certainly can have an acceptable outcome. And I thank you for this. If anyone does want to reach me, you can reach me via the Turquoise Study Club website. And I'm going to stop the screen share, gentlemen. So, Serhat, if you could just put it back, I think we're good. Okay. Guys, I hope that was okay. I didn't take too time. Now, any questions? All right. I know, Pantelis, you're tired. I'll just read the question. I see there's one.
Would you like
well,
me to
I don't want you to be
you?
tired, Pantelis. You're going to do 4 lectures today, so.
I'm going for a marathon next. So this seems, again, sugar excuse. I mean, do we have any other viewers?
I like their questions.
Just one. All right. This seems the best minimal invasive treatment you did for the asymmetric biting patient. Can you a little describe how to
again,
measure
for
with TechScan?
disclosure, I have no financial relationship with them, and there are newer occlusal analysis machines on the market. I'm quite familiar with TechScan, but gentlemen, is this available in Europe as well?
Yes, it is. Yeah, it's and as you say, that there are a couple of new brands that have come to market, but TechScan seems to be the one. I mean, I have a T-Scan unit from about 10, 15 years ago, and they've not too long ago updated both the software and the hardware on it. So they're working hard to improve the product.
Yeah, for sure. So in answer to your question, Sugar, excuse, which I love that name. It's one fantastic name. Essentially, TechScan is just a force plate, and what it does is it gives you a capture of the bite in real time. So as the patient bites, you can literally see the markings appear throughout on the computer. So it's quite quick. It's just simply nothing more than a force plate. So you'll watch it live on the screen, but you can also have the patient bite in centric, in protrusive, in lateral obtrusive, and it'll actually capture things like point of first contact. It can capture the total amount of force distributed. It can capture a left side versus right side. And what it does for us is in real time gives us a very nice idea of where you may have some type of deflective contact that can be damaging to our restorations or to the patient's dentition.
Okay, let me ask you a question, Arthur. Was the T-scan diagnosis crucial for the treatment plan, or you could do without?
No, certainly you could do without, right? And I was being a little bit cute by using it. However, my concern with some of these cases, because that first case I showed is for me is an ortho case without question, and that's why those cases I used to refuse. But now what I want is I want some type of justification. She had a very, very awkward, if you will, bite pattern, because she would literally occlude and then kind of slide her jaw over so that she would be in some type of contact on the side that was very, very light. So did I need the T-scan? No, but it made things very, very easy, because what we would do is place composite, have her bite a few times, and we would just watch it on the computer screen. And then I do a little bit of adjustment, place the T-scan, have her bite. So it was a very nice way for me to document her occlusion, monitor changes in occlusion over time, and way to hone the occlusion during the actual procedure. Because articulating paper works quite well, but the problem is it's a static point. The beauty of the T-scan, as Andrew would attest to, is that it's a dynamic reading. So you'll actually see it as soon as the patient touches, right? Because remember, there is some ability for the patient to flex a bit. But when you see that point of first contact show up on the computer screen, you know where to look for it. Whereas if she just bit down, you are going to see several markings, but you don't actually know which is the one that would be most crucial. So
because I have no experience of using the T-scan, how do you locate where you have to reduce or where you have to adjust the composite, for example? Right. How do you locate from the markings to the teeth, to the action?
Right. So we will actually use both. And I don't know, Andrew, if you want to speak on this as well. And I don't know if it's going to lead to your next presentation. But what I would do is I would have the patient bite with the articulating paper, and then I'd have them bite with the T-scan. And I will just, it is not exact, but if you know the region, say number 1-6, and I see that that's a high point, well, I'll look for that marking on the paper, and I'll adjust that point first, or this area first, and then have the patient re-occlude with paper and then with the T-scan and see if there's any discernible differences. And again, it's a very nice way to hone in real time. And that's the difference that made it for me, especially in a case like the first case, which is obviously not an idealized case, but it certainly helped to stabilize her bite. She's almost 2 years now. So
I think I'd add to that in terms of the more I evolved with the T-scan unit, the more I found it great for post-op finishing in the way that Artie did here. As you quite rightly alluded to in terms of the timings of the contacts, it's also the intensity of the contacts. So in some of my teachings with my one of my mentors, John Coyce, he likes to look at using 200 micron articulating paper to ensure that we get what is effectively a kind of mini long centric, where you free up the anterior segment, which is great. But I guess the difficulty is if you're looking at bilateral simultaneous posterior contacts of equal intensity, when you're using something like articulating paper or shim to then lock in, you don't know what the intensity always is. And so as a measurement device in terms of the intensity alone, and secondarily in my hands to the timing, I think that's really useful. In terms of then locating, again, it's one of those experience, you get a feel for it with the experience over time in terms of the wafers are size matched, not exactly, but they are size matched, and they are sort of visual dividers as well on them. So you get an idea as to where the segment is contacting onto what part of the wafer, and thus it then illustrates on the software.
Andrew, what thickness does the sensor has? I mean, is it equivalent to the 200 millimeters paper, or maybe less or more? I don't know.
I believe from memory it was less than the 200. Adi, I will find that. It was a question I was asked years ago, but I believe from memory it's less than 200.
I believe that's correct, but I could be wrong.
Yeah. So when you when you do the fine adjustment at the last part, do you reduce your paper you use, the thickness of the paper you use, I mean, to 40, maybe down to 8 microns, or do you perform any different protocol?
Personally, I'll start with what in my hands was the sort of the lowest common denominator, which would have been the T-scan, and then I'll move on to my 200 micron, make sure I'm free on my anterior segments. Posteriorly, what I want to move I want to reduce the occlusal footprint. So I'll use the 200 posteriorly, take that down. So I've got point contacts that I'm not only visualizing, I'm also listening to, as odd as that sounds. So I'm hearing a clear and crisp contact when the teeth meet. And then I'll move on to, and actually nowadays I just move on to shim. So I know that it's locking in the correct, you know, in the desired positions.
So we have a relative question. We greatly appreciate for great topics how we should give correct directions for monitoring occlusion.
Okay, if I can help with that. I think the first thing, as Artie did there, would be to, whatever your case finishing procedure would be, if it be a tech scan or if it actually be a more modern day digital scan, because I find I scan all of my patients before, in provisional stage, and then post-op stage, and then recall stage, simply because you can either do it yourself by getting an overlay scan or send it to your laboratory who will do overlay scans for you. You could even get silicon indices fabricated on the basis of those 3D prints. So there are crude but effective ways of modeling the dynamics of your occlusal stability.
That's a great point. Just to Andrew's point, we do scan these cases and keep them as sort of the patient's library. The beauty of digital scanning, and in this case, I took the photo out, but I scanned her, is that we can keep that scan and actually overlay it over a scan we're going to do in 6 months, to a scan we're going to do in a year, to a scan we're going to do in 2 years. So we can very, very easily observe the changes in occlusion and the changes in wear as well, without having to keep the models physically in stock. And the beauty is that if you're going to try to compare one model, you know, from 2 years ago to the current one, it can be difficult. But with the software we use, and I use 3Shape, we overlay the models. So you can literally see any changes in wear right there. There's no need to change, and it'll actually give you any differences in dimensional alterations.
I think digital is changing the game, actually. I think this is very, very helpful, and probably in the future, in the short future, we will have several publications which you will calculate wear according to this method with overlaying the 3D scans. Gurvinder, any comment on this?
Yeah, with 3Shape, you can go with patient monitoring. So if you have got wear cases where patients, you know, you can mention that they have got wear, you can actually scan them. There may be, you know, saying, look, you know, I can't feel any issues or anything. So you can then scan them 6 months or a year later and actually see the progressive wear. So you can actually physically show them a screen whereby, look, your anteriors are still wearing, or your upper six is still wearing. Whereas, you know, conventionally and by analog, by taking models, it's virtually impossible unless you have substantial wear, which that in itself is a problem. So if you then monitor that patient for 5 years and say you've taken off 1 millimeter or 0.5 millimeter, it's quite an issue. Whereas this way you can scan and actually monitor the patient much easier. That'll only become greater because as each scan that we have, we will have a library of our patients to monitor over 5 years, 10 years, 15 years, what treatment works.
Oh, guys, thank you for your input. I just want to ask one question to the panel, and then Andrew, I'm going to ask, if you don't mind, to please start your screen share. But how common is and I know we're all general dentists, I believe, or general practitioners. No, Andrew, you're a prosthodontist, I believe, correct?
No, I'm general.
Oh, you're general. How many of you are doing orthodontic treatment on your patient, or is it more common to refer where you are? I'm just curious, just to get a consensus. I do quite a bit of orthodontic therapy in my office. I am a general dentist.
I'm a general dentist, but again, I've just started.
Everybody.
Yeah, I've just started a course on that for the simple reason we're referring so much. And I want to be able to spot what treatments are, not necessarily do the treatments, what can actually help me, because most cases I'm finding now, whether it's restorative or prosthodontic work, will have an element of pre-restorative or pre-prosthodontic work. in terms of doing ortho.
Absolutely.
Okay, let me take the turn on this answer. I do minimal orthodontics in terms of tilting. When I need to tilt the teeth to improve the position of the teeth in order to be more minimal invasive, when I want to interfere somewhere, I do. I mostly do clear aligners, Essex setups and stuff like that. But when I need to move a whole tooth, or have more complex movements to perform, I like to refer, because I don't have the specialization on this. So I'm trying to be minimal orthodontics.
And Andrew?
Yeah, I've been implementing kind of limited span orthodontics, I guess, again, as with Pantelis, using clears and removables for about 15 years. I do a little bit of sectional lingual work where required, although in latter years I've done less of that. As one of these things, you gain more knowledge, you shy back a little bit. So I'm also enlisted with some training further at this point in time. But I find it, as part of my prostho cases, I find a lot of the time, particularly in this country, I'm unlocking anterior constrictions an awful lot. And I believe that certainly in the population I treat, I think it's vastly underdiagnosed. So consequently, I find myself either retroclining lower anteriors or proclining anteriors as part of my increasing vertical treatment. Obviously, that's subject to the ideal incisor ledge position of the uppers, but that's been the mainstay of a lot of what I do. I do a little bit of equalizing diastemas, so that if I were to bond to them subsequently, you're then bonding to an equivalent space. So I do a little bit of that, but that again is taken with a pinch of salt, because some of the time that requires bodily movement. So if it's bodily movement, it's over to the orthodontist for me.
Thank you for that, Andrew. Andrew, I'm going to kindly ask if you don't mind to just provide us with your screen share.
Sure thing.
We'd love to hear from you.
Okay, thank you. So the following on from the presentations so far, what I really wanted to show is how we can apply minimal intervention techniques to the anterior and to the posterior dentition, especially when we're dealing with form corrections that are required at the request of the patient. But in actual fact, when you go round to diagnosing these things, it comes down to a degree of tooth surface loss and loss of the vertical over a period of time. So I'm just going to highlight a case over this brief period of time. But as we all know, tooth surface loss can occur from a few of these major types here. So we could be looking at attrition, erosion, abrasion, and abfraction. We are looking at a trend, certainly in the UK, where we are looking at increased prevalence in younger age groups. And where that is the case, we're looking at increased levels of erosion and in some cases attrition increasing. Now, there can be an argument to say that, well, you know, is there an increase in dietary causes for that? Is there an increase in internal sources of erosion through stress, anxiety, medication, and what have you? And of course, the thing that is a topic of many different views is, do malocclusions, or can malocclusions actually intimate and continue and progress tooth surface loss? It's my opinion that malocclusions certainly can. And if I give you the example of class 2 div 2 relationship giving shear type anterior tooth surface loss. So with that, I'm going to give you a case here, a young chap who's in his mid-30s, attended to my practice, looking to want to improve his smile. And as with many people, he's explaining some of the layperson's terms in terms of saying, okay, well, I just don't like the appearance of my front teeth when I smile. My significant other says that I don't show enough of my front teeth when I smile, etc., etc. Now, ironically, this individual was the son of a dentist, that I used to work with. No pressure there. And of course, his rhetoric on this was that he has very small teeth. He always has had very small teeth, and as such, he feels that this is getting worse, and he would like to do something about it. Most individuals, as Arthur pointed out, would intimate that, look, you know what, I want to have some veneers because this is what I look up on social media, on the internet. So please, can you supply with some veneers? In this case, because the son of a dentist and having some advice from his father, he was absolutely against wanting to have his teeth repaired en masse. So it was something that automatically wasn't going to be an option, which actually I was very glad of. It wouldn't be the sort of clinical technique I would apply in this case anyway. But I noted he had no previous orthodontics. Now, if we start to look close up at the situation, we can start to see that the tooth surface loss, certainly on the anteriors, is greater than we want it to be at an individual of this age group. We can also start to see a couple of factors here, such as protrusion of laterals. In this area, we've got a very slight white spot here, so we need Gurvinder on the scene. But the buccal corridor areas seem to be not too bad. When you try to apply the idea of a typical kind of positive smile arc, you can kind of see that some of the problems lie simply around these upper anterior areas of the lateral and central incisors. On the face of it, you think, okay, well, that's not too bad. Perhaps get away with some edge bonding and keep it fairly minimal. So that was an outline of what we felt. Okay, well, this could suit the individual in question. If we look to increase the edges of the incisor edges in such a way, then that would perhaps satisfy the brief and keep things simple. So on a slightly larger scale, we're then looking at the proposal of the incisal edge being transposed from one position to the other and analysing that in terms of the teeth in the face, as John Coyce aptly puts it. But here's the problem. And when you start to look at this photo, you start to get an idea of some of the malocclusion elements that may have started to cause this tooth wear over a period of time. So if we start to look at certain aspects of where the limiting incisal edges and the interferences with the lower incisors start to occur, we start to get a little bit more concerned. We start to appreciate the protrusion of this tooth is in part down to the fact that this canine tooth position is what it is. We start to appreciate that as nice a condition as the lower anterior teeth are, because even here you can see the pericymata, you can start to see that there are certainly barriers to extending the length of the teeth where that's concerned. So you start to think, well, you know what, we really do need to involve the orthodontist here, because actually we need to unfold these lower anterior teeth to then create space for these upper anterior teeth to be corrected. And if you look at the position there of where the ideal position of the incisal edges might want to be, you can see that clearly there would be some interferences here that would simply not allow space for the restorative material to be placed in a decent methodology. But of course, we know that it goes far, far further than just the anterior teeth. It also involves the posterior teeth. Now, forgive me for these photos because there is some saliva on there, so it's a little bit difficult to see, but I'll try and talk you through this. If we look at the occlusal surfaces of these teeth, of course, the individual in question is unrestored. So we were really, really reticent to want to perform any form of invasive therapy whatsoever. So if we look at his upper arch-wise, the upper arch is perhaps a little bit narrowed in this area, but otherwise fairly well spaced. If we look at the lower arch curvature isn't too bad, but of course we come round to this area in the lower anteriors where it's fairly flat and crowded, and you can start to see where a little bit of incisal edge wear has started to occur. Now, this was the significant finding when we were doing the initial diagnostic work on this case, but even more significant was this. Now, when you start to then look at the cusp tips of this individual in the posterior dentition, at the age of 35, you're starting to see these wear facets occurring to a fairly significant level on the buccal segments. And this was actually cause for concern. And the reason it was cause for concern is in one individual, you might think, well, I can accept these wear facets that are recurring because, you know what, most of them are still into enamel. This perhaps is starting to wear into dentine, as is this. But that loss of vertical is actually having an effect upon this. So the thought was, if we were to simply restore those worn wear facets to the posterior teeth, thereby raising the vertical, would we or could we just about get the space to restore the anterior teeth? Of course, to do this, we had to know that the joints were stable and that we were in a stable position in respect to centric relation versus centric occlusion. So here were some of the clinical findings. The individual, generally speaking, had pretty good oral hygiene. No caries experienced and an unrestored dentition. There was, to my mind, tooth surface loss of a relatively significant level given the patient's age. If I saw the same extent of tooth surface loss on someone double his age, of course, naturally, I might not be so concerned. There were anterior interferences and crossbites present, and as a consequence, we saw evidence of incisal edge wear and lower anterior crowding. As mentioned, we had some protruding lateral incisors, but most importantly, and this is the point to get across, those posterior wear facets that were actually incredibly important to the diagnostic value of this particular case. So on the basis of that, the models or the dentition was scanned and then sent to the laboratory to then say, right, what we're going to do here is maintain point contacts on the posterior teeth. I had then ensured that the condyle apparatus was indeed stable, and that we could then simply just raise the vertical, and let it be known that that's not always the case, and sometimes we need to do a little more work to then try and stabilize the mandible. So in this case, we decided we wanted to add X millimeters of incisal edge length to suit this individual. And again, working from that extension of incisal edge position of the upper centrals, we then worked back and then figured out how much to then add to the posterior dentition. We then have a wax up, a digital wax up fabricated, and then take a model of that and then apply it. This is just an overlay mock-up using bisacryl on top of the anterior teeth, running round to the premolar area, as you can see here. What it did show is for the aesthetics to be ideal, there needed to be a little bit of enamoplasty that took place upon the upper right lateral tooth. And that was a question that was then put to the patient to then say, well, how do you feel about having to do a little bit of adjustment there so that you don't end up with a tooth that appears to be more protruding than the other teeth when everything else is then effectively aesthetically fixed for you. He took it on himself to then think about this, and we decided that it was worth to conduct that bit of enamoplasty, as you'll see shortly. But here is the mock-up, which I feel is massively important in terms of then trying to deliberate the correct incisal edge height, but also figuring out how much space we require on the posterior. So you are in effect, on a stable condyle apparatus, you are effectively building up the posterior teeth to ensure that you can get point contacts on the posterior teeth and minimal contacts on the anterior teeth. Not only that, it was also a case of making sure that we can find out the dynamic smile. And to do that, what I am doing here is taking some video footage of the individual to make sure that certain aspects such as the buccal corridor, the incisal edge length, the phonetics can be assessed and confirmed as being suitable for that individual. So it's important in these cases we get not only the static position, but also the dynamic position. And there he's looking to his girlfriend. She seemed quite happy. Anyway, we're looking also at the intraoral mock-up to assure ourselves that the thickness of those additions is something that is going to be viable. He actually did some research to then show that we need at least 1 millimeter thickness of composite resin addition to ensure that the material actually has a chance of not breaking down over a shortened period of time. So we must have an idea of the thickness of the incisal, or the facial, or the palatal, or the occlusal additions that we're going to apply. And these types of mock-ups, when we remove them and measure them with calipers, can really help us. So we come to treatment, and here's the teeth isolated. You can see still that you have areas where we have some staining interproximally. We probably have some biofilm here. You can see that we need to look to remove. Here's the index we're putting into position. You can see there's quite an extension. I don't believe that's fully seated at this point in time, but we work using an index of the 3D model of the wax up. We move forwards, and here is just the area that which we had to perform a little bit of enamoplasty just to remove that protrusion there. On the left-hand lateral, the protrusion wasn't quite as bad as you can see. So here what we've done, we are utilizing a couple of things. We are utilizing some tri-plaque disclosing gel to ensure that we can highlight where the biofilm remains, and then we are using air abrasion to remove any remaining biofilm, which would then prevent decent bonding and prevent premature delamination and failure of the bonding interface to the natural teeth. Really important part to play. So in these three images, you can see I've etched, and then here we've got the dehydrated enamel, applying some iBond universal bonding agent, which is my standard on anterior teeth. And it's these types of instruments that I'll tend to use. It's the LM Arte instruments, as highlighted by the Italiano think tank group, which I find to be an extremely versatile set of instruments, but those are the ones that we used here. And crudely speaking, here's what we then started to do to build up these crude palatal shells that were built up in a translucent composite shade. You can see they're not the tidiest at this stage. They don't need to be at this point in time, but they give you an idea of your anterior guidance and your perceived incisor ledge levels. And at every point in time, what I'm also then doing is ensuring that I'm not going off point by utilizing my calipers and measuring the 3D print model of the desired wax up and making sure that the length of those incisors matches, so I'm not going off course. And that was an integral part to this. Here you can see I'm using a matrix system called the Polydenture Unica system. And this system allowed me to then start to build up both the incisor ledges and the proximal walls at the same time. Now, picking up on a very valid point that Gurvinder made up on is that most of these cases do not require the covering of the facial surface of the teeth, and I would wholly agree with that, because a lot of cases that we see, there is no accommodation, there's no consideration or very little consideration for lip support. Now, in this case, the lip support was deemed to be suitable for me to cover the facial surfaces, and the only way I knew that was by utilizing the mock-up and taking the video footage to ensure that the lip wasn't then set outwards on a buccal basis as a consequence of the buccal of encompassing the buccal surface with the bonding material. And as such, I chose to do that. So you can see I'm starting to build up some of the hyperchromatic dentine underneath where I've made that, and I'm putting this, striating this out into mamelons so that we're getting some form of incisal translucency. You can then see how I've started to use this matrix system to then build out the proximals and then the cervicals. Now, let it be known, Arthur brought up a really, really important point, because there is no intention for me to keep these ledges like that. If you keep the ledges like that, you're going to instigate soft tissue inflammation, and that's obviously not acceptable. So my point here is that I then have a point to which I can then build the composite to. And then I can smooth that down as part of my finishing process to ensure I have a decent and smooth gingival embrasure. So here's the further part of building up, and I'm putting a little bit of incisal stain in place there just to give us a little bit of chromatic characterization, and then applying the enamel over the top. And then you can see here already how I haven't covered the entirety. It was simply a guide. Now, some may argue, well, that's sort of overbuilt in that area, but I'm simply going to cut that back at a later point. So it is then down to then creating your primary anatomy for your line angle establishment. So ensure that you've got a degree of symmetry between the central incisors and then the lateral incisors for your sort of basic elements of smile design there. And then looking at some elements of my secondary anatomy by putting in these developmental grooves. You can see I've segmented the teeth up appropriately so that I can get a bit of symmetry once again. Once I put some tertiary anatomy in place and then conducted a little bit of an initial polish, this is the immediate result afterwards. You can see there's just a little bit of inflammation around this area, but you can hopefully see where I've then smoothed down some of these areas. There's a touch of recession here. I smoothed down some of these areas to ensure that gingerly we're still in a hygienic place. So again, here's the end result in terms of then building both the anterior and the posterior areas up. Now, please note, on the posterior, all I have done is built up the composite on the wear facets there to create point contacts there. And that is both on the lingual surface, on the lingual aspect of the occlusal surface, as well as on the buccal surface, to raise the vertical to allow accommodation for an increased length here. And you can see here, I've now got acceptance of this area, and here. And this shows you very crudely some of the areas which were then built up prior to then sort of ensuring that I had finished these areas, so that I've got an idea that I've got point contacts in the areas that I want them. And as I mentioned earlier, what I'm going to be looking to do is finesse these areas, bring down the size of the occlusal footprint so that I've got bilateral contacts on the teeth that I want them on, to ensure I've got a degree of anterior disclusion, and this is using 200 micron articulating paper. So we go from here, post-polish, post-review to this point, and this is the difference that we get from pre to post. Or I'll just bring that back for a moment. So generally, the patient was very pleased with the situation. It took him a little while to get used to the increase in vertical, but because he was much happier with the aesthetic result, he accepted that. You can see, hopefully, that the upper lip hasn't been protruded terribly, because there was space to do so here because of the narrowness of the arch in this case, and we felt that that worked to his advantage. So in conclusion, additive procedures applied for minimal techniques can give you really predictable outcomes. You do need to plan these, of course, and you need to ensure that the tooth surface loss is diagnosed in terms of its etiology. You do need to ensure that the functional component is stable. So you need to ensure that the condylar apparatus is in a stable and repeatable position. And that functional component may result in the need for orthodontic intervention or simply restorative intervention. You know, I was just fortunate that we could manage it restoratively here. You have to ensure that composite thickness is of that minimum 1 millimeter, and allow the time for effective communication to your patient to ensure that they are aware of some of the changes that are going to occur, not only aesthetically, but also functionally, such as cheek biting initially because the vertical's been raised, masticatory changes initially, and give them a timeline of how long it might take to get used to that. It's really, really important that follow-up and some form of early stage protection is offered to the patient. I tend to offer Essex retainers as a very, very minor modality of restoration protection to be worn at night, to which I tend to wean the patient off of after about 3 months, once they're used to everything. So I hope that gives you some idea of the types of things that we can achieve using these minimally invasive techniques. I know I haven't gone through all the technicalities given the time that we have, but I'm happy to answer any questions at this point in time.
Thank you, Andrew, for that. That was an absolutely phenomenal outcome. So thank you for sharing not only your philosophy, or rather not only your outcome, but as well as your philosophy. Sure. We are waiting for some questions. We do have one here. And you mentioned actually in your concluding statement about the getting them used to the new occlusal when you build up the wear facets.
Yeah.
How long are you letting them get used to the occlusion before you attempt to restore the anterior teeth? Like, what is the timeline?
You know, it's funny. Actually, I was scared of this when I first started doing this procedure. And actually, John Coyce reassured me, in as much as patients feel much more comfortable when you have this theory of bilateral simultaneous contacts. Not only that, but point contacts. If they can feel there to be a crisp, clean contact, and actually they tend to get used to this phenomenon real quick. And I have now, when I perform this procedure, I tend to find that actually it's a matter of weeks. I think in the situation where I've got a patient who is what I would define to be a true bruxist, someone who just wants to destroy whatever they have, whatever you put in place, that's when you get the resistance. But in terms of a true bruxist, you tend to get a very different type of starting scenario, and the alarm bells can start ringing at that point in time, and that's where you alter your treatment strategy based upon that.
Thank you for that. And type of composite that you're using to build up the facets? Is it micro hybrid, nano-filled, nano-hybrid? It's
actually a nano hybrid. I mean, I'll tend to use Venus Pearl on the posterior dentition there. It's a fairly opacious material. It's a hard material, and in my hands, I tend to get pretty good longevity out of it. Anteriorly, that was in Spiro. That I was using optically. It's a wonderful product to use. It's a very strong and hard product to use, and it gives you great sort of visual effects in terms of translucency where need to.
I think, Arthur, just adding to getting patients used to the changes, particularly when a moving or kind of moving the incisal edge position. So somebody who's used to wear on the front teeth. It's quite tempting, as soon as you sit the patient up, you give them a mirror, the first thing they'll say the teeth are too long. Remember, you've planned this phonetically, aesthetically, functionally. Is not to be tempted to kind of pander to the kind of advice to say to reduce the incisal edge. Is stick with it, because what they'll do, it takes them just time just to kind of look at themselves and get used to by over a week. It's very rare them to come back a week later and say, they're too long.
I'm sorry, just to clarify, you said a week typically is what you would find. Okay.
If you find in a week's time that you're still finding these are too long, I'll adjust them. But I'm not going to adjust them today, because what they're doing is they're not used to their teeth being longer. Physically, when you give them a mirror, they're used to seeing themselves for the last 5 years, 10 years, 15, 20 years. You've suddenly made their teeth much, much longer. And it just takes them a little bit of time just to kind of psychologically look in the mirror to think, actually, you know what, this actually suits my face. This is correct. It's very rare that you have to then a week later reduce the incisal edge. It's very tempting to do it on day one.
And just to pick up on that, because that's very, very true. The first thing that a patient will do, and we all know this, is that they'll pick up the mirror and they'll go like that. And that's no, they're too long, right? I mean, that's typically what happens. And so one of the other reasons for taking the video footage is that actually I'm having my assistant or me talk to them, and I'll try and crack a joke or two as I tend to do, and they'll laugh quite naturally, and then I'll send them that footage. I'll take away all the audio. I'll just send them the footage. And that's when they get a really good natural visualization of the lengths of the teeth, to which Gov's saying, because actually otherwise their context is not there, it hasn't developed yet.
Very good. Pantelis, have you had similar experiences?
Experiences on going to the mirror with a mock-up?
Yeah, one or two. If you're raising vertical, how often are you finding patients? Or what's your protocol for patients?
Well, I always, when I have to modify, especially in the anterior region, when I have to do modifications, I always take a video before and with a mock-up on. With the video, I am asking them to count in Greek from 60 to 70 because it has lots of S's. So I just use this to estimate if the incisal edge is in the correct position or I have to modify this. Once I am good with it, I don't provide them the option to go to the mirror. But most of them have the mobile phones and start with the selfies, Anyway, I ask them not to share their opinion about it because, it's like changing the haircut. I mean, it looks totally awkward to them. I prepare a file with the pre and the post, let's say, video and pictures. And then I say, don't answer to me if you want to do this way or a different way now. You will answer to me a week after that. So I mail them the video files and let them think. So they sleep on it actually, and they show this to their husband or wife or friends or family or whoever, and they take their opinions. So then I have a more let's say a bigger sample of opinions. So once they give me the go for it, I'm confident that that's the plan they want to follow. So I go that way.
Thank you. So
I'm sorry. I'm sorry. I think that I disappointed Sugar Excuse because we have no more questions. please post your question.
That's because Sugar Excuse is really me.
So everyone will be more than happy to take your questions and comments. Please keep them coming. If you have any questions, please post them in the comment section on YouTube Live. Pantelis, I do have to ask, I know you are lecturing very soon. Is there anything you would like to add? Would you like, I know, and by the way, if anyone does not know, Pantelis did a phenomenal presentation earlier on the Free From Caries Symposium on color. Please see it. It will be available on this channel. You just have to find it. It is recorded. All of the sessions for this symposium will be recorded, both through University of Kent, and we also have on the Turquoise page. Pantelis, I do want to ask, would you like to... Oh, Sugar Excuse said we love the panel.
Yeah.
Thank you, Sugar. Thank you, Andrew. I mean, sorry, thank you, Sugar Excuse. Thank you, Sugar Excuse. Really, you helped us a lot with the questions. Pantelis, would you like to add anything?
I would like to add that I would not like to present my cases because after that I don't have anything to present. Of course, it is a joke. I mean, the level of your clinical skills, guys, it's over exceeding my skills. So I'm going to give it to the more scientific or more, let's say, intriguing part of the presentation. So whenever you're ready, I can start.
Please, Pantelis, if you'd be so kind.
All right, so let me share my presentation. I think it was like, okay. Yep. Can you see the presentation?
Yes, go ahead.
All right.
You're good.
So I'm going to intrigue things in a way that how minimally is the minimal. I mean, okay, can I ask your opinion, guys? What would you do in this situation? Would you prepare or would you prevent?
You know, to me, the first molar on the lingual aspect looks and the occlusal aspect looks a little more suspect.
Yeah.
So I wonder. If
all right. So but let me say that according to the AACD criteria, I mean, at least the not the updated ones, but the first ones, those lesions should not be touched because they're AACD 3. But to me, this is a caries lesion, so I need to prepare. So in this way, I would like to say that sometimes we have to be more aggressive in order to be preventive, because preventive does not look on the short future, but looks on the long future, on long-term success. So in my opinion, those are lesions that need to be opened, especially when at the first lower molar we have this shadow. And let me proceed to, okay, this was easy to to decide. This is the second premolar, so I had to change this restoration anyways. But then I moved. Oh, I'm sorry, something is missing here. Okay, I don't know why. Let me go back. No, I'm gonna outside. Yeah, most critical. I want to show you this picture. Okay, I'm sorry about this. Okay, I did something before. Just let me undo this, because I might have deleted some data. No, I don't have it. Okay, I will go through this picture. Okay, just let me tell you that I had a tunneling. I mean, this lesion and this lesion were unified. So guys, would you remove or would you restore this enamel bridge above it?
I think if I could access it and the enamel was intact,
all right,
I would leave it, but it would also depend upon the centric contact.
Yeah, I was just about to say that it wouldn't be important on where the pre-existing contact was.
Okay, so yeah, Arthur?
Same. I would, and
right.
also the thickness of the underlying dentin as well.
Okay, so actually I have no literature reference to this opinion. I mean, it's my opinion. I might be it might be the same with your opinion, or with or differs with different people's opinion, but I always choose to leave those bridges whenever I have those one, because I do rely on the adhesion, and the adhesion also occurs on the pulpal side of the cavity. It can occur on the reverse, on the rear side of this bridge. So the only thing that we need to take good care of is not to leave any void behind. Then the mechanical properties of the composite will actually act exactly the same as the dentin. But this is my approach, and I want to discuss why I do approach this kind of stuff like this. Okay, I have made some mistakes on the presentation here, the way it's presented. This is the acid process. Okay, then we have the filling of the cavity. I'm going to go fast because this is not the interesting part. You guys have done so much better work. Okay, then the class 2 on the premolar, which is not the best work I have ever done. So then we come to this conclusion. And what is actually worth seeing is the 4 years in function. And this is the solution of the argument. We see that we have some calculus accumulation here. We have the contacts there, but you can see that everything is working so fine. Okay, so I would say that in my opinion, this is a proper method to preserve the enamel. And what is the most valuable thing to this is that the enamel is the golden standard for the adhesion. So when we increase the enamel surface, we may get better solutions. But okay, this is my opinion. So is it predictable? If you apply good techniques and you leave no voids behind, I think it is predictable. But this, again, this is my opinion. So because it's only an opinion, I decided to see what the other colleagues of ours are thinking. So I referred to the dental private group in Facebook, which is called Dental TTT, which has like 6,800 members. And I have posted this picture, asking with a poll, what would you do in this case? Would you remove or would you prepare to single cavity MOD? Guys, can I have an opinion of yours?
To be honest, I
I
might be inclined to remove.
All right.
Yes, me too. In this particular case, I just feel there's a slight fracture on the discoloration and these coronal parts. Maybe perhaps.
Good, but let me ask you, how about the cusp distortion? I mean, if you remove, you will increase the distortion of the.
Correct. That's true.
Yeah. So what would you do? Would you go for an onlay?
Yes.
In all honesty, yes. It well depends what I would find, but I'm in agreement with Andrew on this one, especially that buccal cusp is going to, and we know that premolars are especially prone to, cuspal fractures. Again, just looking at this picture, I might be more inclined to, I can go with what Andrew had spoken to, and that's probably do an onlay, likely with buccal cuspal reduction.
Both buccal cuspal, or maybe the buccal, just the buccal, because the lingual cusp is thick enough. I don't know.
Just buccal cuspal. Yes, sorry, just buccal.
Okay. But okay, let me make this more difficult. You're practicing in Greece, and Greeks have no insurance, so they have to pay for their dental work, and this is an expensive one. So would you rely on the direct? If you rely on direct, would you remove the bridge or would you leave the bridge?
First, I would say "Ochi malaka," and then I would say, "Let's fix this tooth the way I want to."
Okay, so I made this question, and the option at the poll was prepare a single cavity. The second option was leave and restore as is. And everybody who was willing to participate could add any option that would like to. So let's see what our colleagues have responded. 117 responded that would prepare in one cavity. This is the 55% of the people that responded. 78 responses, 37% would leave. We had, I don't know, it's 3.8% would send blessed. I mean, I always send blessed anyways. And we had a response that was saying that would do inlay. Okay, 6 responses, excuse me. And we had 1 response which would extract and dispatch to Cycladic Art Museum. Okay, in those groups we have fun as well, so this is obviously a humor, but this is probably due to that the shape of the premolar is reminding of this ancient statue, which is like 4,700 years old, which is at the Cycladic Art Museum, which I would suggest if you ever come to Athens to visit. So I found this very funny, so I needed to say. Then a couple of months later, I did the same poll, but posting this picture. So the options were either to preserve the transverse groove of oblique ridge or to remove it. What would you guys do?
I'm giving this one to Gov. Go ahead, Gov.
I would probably remove. Looking at that looks very, very thin. Particularly, it says the isthmus there is very small compared to the side. So that would be my concern.
Anybody?
I would remove it. I would have removed it.
Do you know, I'm going to go out on a limb and I'd keep it, because if it failed, I could repair it easily.
Well, the differentiations to this is that this is an extremely important occlusal point. I mean, this is the oblique ridge. This is the point that the lower jaw meets the upper jaw. So if you remove it, you have to reconstruct it precisely. So I don't know how easily or how repeatable can be this one. Okay, we have some stamp techniques and stuff, but I would go with Andre, because if it fails, we can repair. So why not try to keep it?
The only thing I would add to that is because there's an enamel ring of the occlusal surface. If it was an enamel or a DO, then that would probably potentially change my thinking, because the actual occlusal surface is intact in the proximal areas.
However, However, Garth, have you ever performed a reverse bevel?
Sorry?
An internal bevel, have you ever performed it?
No.
No. Okay. So let's go on the answers of the colleagues. 60% have responded that they will preserve. 27 will respond that they remove, and 3 they responded that depends on the remaining thickness. Okay, you can see that there is an increase of the opinions that they ask on the percentage of the opinions that they would preserve this oblique ridge. So just the location is changing the response percentage. So how about this one? Preserve the labial enamel shell, remove the labial enamel shell, or add a different option. How would you treat this case?
I would leave that.
Okay.
Absolutely preserve it.
But everybody says preserve it. But let me ask you, this is on a supported enamel. What happens?
It is, but you're gonna still get a very strong bond to that enamel to the underlying restoration as well.
Why not this applies to the oblique ridge that we saw before?
That isn't under the same load.
Okay, the load here comes at the vertical direction.
Yeah.
Let's see the response. Yeah, let's see the responses. I mean, we do not disagree actually, but we make an argument just to have a conversation which is profitable. Okay. The percentage that would preserve this labial enamel shell are 99%, which is an extremely high response rate. So only one colleague of ours would remove the enamel shell. So, but still we are under the same adhesive principles, the same mechanical principles. Maybe I would say that here we have more load into the labial enamel shell. Why do we have this kind of differences in trend? I mean, for a random enamel, we remove more easily. For the oblique ridge, we're less confident to remove. For the labial shell, everybody preserves. Why is this trend present? Have you any thoughts about it?
Okay, I think with the labial enamel, if you remove that, you're also going to increase the flexibility of the tooth.
It's the same with the premolar, which I just showed you. It's the same thing.
True.
But why? No, I'm just going to go back. Okay. I have an answer which I might be thinking that is the correct answer. It's what we have learned on the undergraduate studies, because everybody knows that we learn to preserve the enamel just for the aesthetics, to improve the aesthetics. But yet we have seen over the years that this is a method that keeps working and keeps being in practice, and nobody is thinking, almost nobody is thinking to remove the unsupported enamel, which is the labial shell actually. And what I'm saying is that I think that we can do this in different areas, as long as our adhesive procedures are perfect in a way, or we do not leave behind any voids. Because this is a procedure that I perform many years in my practice. I never saw any enamel prism go away. because I know that the reverse enamel surface will be adhered to the composite below in a very well way, in a very constant way. And I know that the mechanical properties of the composite are very, very similar to the dentin properties. So I actually just restore the dentin. And this is minimally invasive, in my opinion. Of course, anybody can have an argument on this. Am I correct?
Agreed.
Nobody. We're free to argue. Okay, that's okay. That's okay. Okay, what I like in Facebook is that we are able, without any efforts, to make this kind of unofficial surveys, because we can take opinions with just by leaving a picture there, and then take and see what our colleagues think. A different post that I've done, I posted this picture and I said, just after the hygiene appointment. I took like 70 likes in 3 days. I left the picture there. Guys, do you see anything? Any comment? Nobody?
No.
I don't know how many have noticed that the patient has 6 incisors. Anybody? What I'm trying to say is that do we know what we see, or do we see what we know? This is the question that I would like to leave behind, and I would like to close the presentation. I don't know if we have to go to the more severe case. I don't know. That depends on your time. I would only like to pose this problematism. So, any comments up to this?
No, but leave it to the Greek to leave us with a philosophical question at the end of the presentation. I'm just saying.
It brings a new twist to anterior guidance when you've got 8 lower anterior teeth. That's a mess with.
Well, a very very good comment that I took when I posted the second with the 6 incisors was okay. Everybody now is face palming because this is offensive in Greek, so it's like because nobody has commented nothing. Okay, it took 70 likes. I was waiting for the comment. Oh, there are 6 incisors. Nobody.
Pantelis, may I ask a question then? When will you cut a transverse ridge? When will you cut that random enamel?
If it fails while I'm drilling, only.
And so you'll prepare an inverse bevel. Would you mind speaking a little bit to what an inverse bevel is?
An internal bevel, actually.
I'm sorry, internal bevel.
Internal, yeah. When you perform the bevel in the enamel which surrounds on restoration, okay, can you imagine the undercut of the cavity? So if you leave this undercut, then you have some prisms which come in a way of an internal beveling. So you have some enamel which is exposed on the internal side of the cavity. So the adhesion on that enamel is actually the same, maybe better, because we don't have the aprismatic enamel like the ones from the outside. Why should I remove this? Is it going to break? Why? I'm going to have the composite. What's a composite? Composite has the same flexure, the same mechanical properties, the same flexural strength, the same as dentin. So if I am very well attached to the composite below, why should those enamel prisms go away? Why don't they on the labial shells? They don't. So do I have any reason at all to remove them? In my opinion, I don't. As long as I can attach to them, because I will have a better sealing of the cavity. If I want to remove it, I will go like this, and then I have to bevel outside. So why should the composite on the top of a bevel be better than a composite on the bottom of a bevel? I don't understand that. It's not rational, but it's what we have learned on the undergraduate. So we keep on doing this. We have a saying in Greek that okay, I'm sorry about this. It's a saying. When a donkey learns a path, then you cannot take any deviation. So we're like donkeys. We're learning to do things in a way, and we cannot critically appraise it. We cannot critically see on that way that we have learned in any way. This happens to all of us.
That's a great point. I mean, it really is. It truly is. So thank you for opening our minds up a little bit. I never even considered that. I'll be honest, I was probably the one who would have ripped open just about any one of them except for that labial enamel. So I appreciate you. You have to be honest. I mean, and it's true. I mean, shoot, if there's anybody that's donkeys, it's a lot of time us dentists. So
I really don't have any literature background to support my opinion on those. It's clearly an opinion. Okay, so this is the basis on the hierarchy of evidence pyramid. So I urge you not to just go and follow my path. Just think about it and think if it fits in your practice. That's it.
Thank you so much. Let's just check if we have any other questions. I think you blew a lot of minds. Maybe that's what happened. I know my mind is certainly blown, Pantelis. So I just want to make sure. A lot of agreements. No questions. Well, gentlemen, I have to say it's been a pleasure. Are there any comments?
I think Sarah said there is a question coming.
Private.
So, yeah. So I think he's going to get via WhatsApp.
Right. And by the way, we want to thank Surat because we have not mentioned him. For those of you who don't know Surat Kokin, well, I'm sure everybody knows who he is, but he is one of the creators of the Turquoise Study Club. And the four of us have had the pleasure of not only knowing Surat personally, but we've worked with him and we've definitely been involved with him with the Turquoise Study Club. So we invite you, please, to visit our Facebook page. Please look at some of the upcoming educational programs. And on behalf of Turquoise Study Club, we do want to thank the people at the University of Istanbul, Kent, for having us to co-host this panel. So thank you very much for that. And maybe Surat wants to jump on the screen a little bit, say hello. Always working behind the scenes. All right, so okay, so I've not seen.
Code 5 cases already have 30% volume loss of enamel, more removal, or intact enamel will decrease the strength. I'm not sure if I understand this correctly. I said that's code 5 cases already have 30% volume loss of enamel. More removal of intact enamel will decrease the strength.
So it's a technique.
It's a comment, yeah. Residual columns of cavity of preparation of teeth classified according to ICDAS-2 or Congress, yeah. Okay, ICDAS initially had no reference on the activity of the actual decay, so it was a picture of a time. It was classifying the decay according to what we see now, not according to if it's active or if it's inactive. It only classified the lesion depth or the appearance of a lesion. I think that NIVAD classification for caries is taking under consideration the activity of the caries. The updated ICDA's protocol, it seems to be taking a little more under consideration the activity, so it's very much improved. So the decision making of if you go and drill versus to preserve, I think it's very much improved according to the AACD principles. Yet there are so many factors that we need to consider when we see a tooth, because we do not just see a mouth, we do not just see a single tooth, we see a patient. So if, for example, I see those lesions which I showed you in a 60-year-old person, I would not touch. But those were in a 20-year-old mouth. So I think that it was a one-way road to me to prepare. Okay, so the age, the plaque accumulation, those are factors for the dietary. Okay, those are factors that would contribute to decision making, in my opinion.
Okay. Thank you, Pantelis. And also, we do want to thank Sugar Excuse. Whoever you are, you were good. Oh, we lost Sarat. I think you. No, we lost Pantelis. Gentlemen, any final comments?
No, it's just to echo your comments there, Artie. Just to thank the organisers for giving us the opportunity to meet in this way. It's great to work with you guys, and always has been, always will be. So, and I just hope it's been of benefit to those that have tuned in.
Yeah, thank you again.
So thank you again from us at Turquoise Study Club. Again, we do want to thank the good people at Istanbul. There he is. Pantelis is back. We were just talking about.
I'm very sorry. I'm very sorry.
We were just saying. There we go. Finally made an appearance. It's none other than Dr. Koken. How are you, sir?
Thank you for everything, and it was a really great 2 hours webinar with your high quality presentation. It was a lovely webinar. Thanks for your great contribution. Thanks anyway.
Thanks for inviting us.
Yeah. Okay, so this is the end of the panel. So I will just close the panel right now on the right hand side. Okay. So see you soon, guys.
Okay. Bye-bye. Thank you.